It's my pleasure now to go on to a invited lecture. Michael Brage is going to talk to us about advances in comprehensive foot and ankle reconstruction. He was a fellow in 1990-91 of Dr. Hansen's, and has been in academics until most recently, but has now come back into the fold, and we welcome him back and look forward to many years with him being here. Michael.
Thanks. I thought I'd just give a primer on total ankle replacements today. So we'll talk about total ankle replacements in general and introduce the controversies of patient selection and implant design and arthroplasty versus arthrodesis. And then I'll just tell you about total ankle replacements in the United States. Right now, the indications for total ankle replacements include a persistently painful ankle, which limits the activity of daily living and has failed the non-operative treatments, including anti-inflammatories, cortisone injections, and braces, etc. Basically, the contraindications for total ankles include a varus or valgus deformity of greater than 20 degrees, missing malleolus as shown here, significant peripheral vascular disease, significant pre-medical conditions and non-compliance. I also think that a total ankle replacement should not be done by the casual ankle surgeon. Advanced neuropathy is certainly a contraindication, extensive avascular necrosis of the talus, and active infection as shown here. Preoperatively, you have to look at the extremity for deformities. In this example, a previous tibial shaft fracture. If you have any angulation of the tibial plafond in relation to the long axis of the tibia that's greater than 10 degrees, you probably should correct that with an osteotomy either before or during the ankle replacement. And then you have to also look at foot deformities. If you have a subtle pes cavus or pes planus, you can probably leave that alone. But if you have a significant deformity of the foot, either cavus or flat foot, you probably should correct that either before or after to prevent abnormal loading of the prosthesis. If you have hip and knee arthritis, it's generally recommended that you address that first. And if you have simultaneous arthritis of the subtalar or talar navicular joints, if you feel that they're painful, you can do lidocaine injections to try to localize that source of pain. And if you feel so inclined, you can fuse these joints either before, during, or after the ankle replacement. And don't forget lateral ankle ligament instability. You can test for that with the anterior drawer and talar tilt, and you can reconstruct the ligaments either before or during the total ankle replacement. Equinus contracture is a huge problem, and this is my own personal decision-making process, but if you can't bring the ankle up to at least neutral position during active assisted dorsiflexion, then you should at least address the problem. It's either an Achilles contracture, a posterior capsular contracture, or gastrocnemius contracture, and you can do a recession of the gastroc mechanism or a percutaneous Achilles tendon release during the total ankle replacement. Now, a mild varus or valgus talar tilt can usually be corrected, but a significant talar tilt exceeding 10 to 20 degrees may represent a contraindication, and sadly, this is based really on anecdotal evidence. There's no real science that's looked at this yet. And a mild deltoid ligament laxity is also potentially correctable, but a significant gross deltoid ligament insufficiency is a contraindication simply because we don't have a good deltoid ligament reconstruction perfected yet. Now, the ideal candidate for total ankle replacement continues to be debated, but right now, in general, we recommend that the patients be smaller or average size. Some authors recommend less than 250 pounds, and either others recommend less than 200 pounds. And there's really no published clinical evidence to support this at this time. We recommend that they be older patients, and the definition of older seems to be greater than 50 or beyond. And they should have no intention to return to impact sports or manual labor, and that ankle arthrodesis is the only other option. Patients with inflammatory arthritis of multiple joints are considered good candidates because they have a presumed limited level of activity. And then patients with ipsilateral arthritis or arthrodesis of the hindfoot or even contralateral ankle arthritis are also presumed to have a limited level of activity, so are considered better patients. But there's no data that exists to confirm the efficacy of ankle arthroplasty in these disease-specific cohorts. Right now, in the United States, all the implants that we use an anterior approach. All the manufacturers offer training courses to learn their jigging systems, and the instruments are really not intuitive by any means. You position the patient with the foot at the end of the table. You can bump the hip if you'd like, and you can perform a popliteal block for pain control. And some systems require an external fixator be placed before surgery. The approach is a midline approach. It's about 15 to 20 centimeters long. It's centered right above the ankle. You try to avoid the superficial peroneal nerve, and you typically develop the interval between the extensor hallucis and the tibialis anterior. Here, as you dissect deeper, you mobilize the deep neurovascular bundle laterally. You stay subperiosteal, and you need to expose the entire medial malleolus, the lateral tibial plafond, the anterior talar neck, even to the talar navicular joint. At this point, you try to identify the roof of the tibial plafond, and you can take an osteotome and remove the anterior osteophytes, typically off the tibia and is certainly off the talus. And you just want to get to the point where the midline of the tibial plafond is. Most systems nowadays employ an anterior tibial alignment rod, and you put a pin in the tibia tubercle and then one in the distal tibia, and then you align this rod up through the long axis of the tibia, and you want it to be parallel both on the AP and lateral planes. And then you can subtract the planned tibial resection at this point. So here is a alignment rod on, and you have a sizing jig in place, and you have to identify the rotation of the ankle. You put ribbons or K-wires in the medial and lateral gutters, and you want to try to get this alignment jig then right in between the medial malleolus so that you have the exact external rotation of the ankle defined. And this is the Pew Agility alignment jig in place, and we use fluoroscopy to try to best to line up the cuts so that they're symmetrical and even on both sides. After you make the cuts, you remove the bone. It's often piecemeal. That's because the adherence of the bone to the posterior capsule is quite severe, and you can never take it out in block. And then you have to start preparing the talus. So after the tibial plafond is removed, then you can usually key off the tibial alignment rod with a talar jig and then place a pin into the talus, which will then guide the talar resections. So here's a posterior chamfer cut guide that's then seated onto that talar pin. And then after you remove the posterior elements, you then put an anterior chamfer cut guide on, and then also do some lateral cuts. And you end up typically with a talus that's kind of conical and denuded of its cortical bone like this. In the agility system, it's a flat cut, so you simply put the alignment talar cutting guide on top of the flat cut. You align it with the second metatarsal, and then you can mark the trough with a pen and then burr it out. You place your trials into the body, and you arrange it, and then you put the final components in. If there's any instability, you add polyethylene thickness to try to stabilize it, and then if there's a contracture, certainly you do your gastroc or your TAL at this point. I like to keep my total ankles non-weight bearing for 6 weeks in a cast, and then I put them in a CAM or ST walker boot for 4 weeks while I start physical therapy, and then you try to wean them to a shoe at 2.5 months. Contemporary total ankle designs, we're going to just introduce those topics. Right now there's typically 3 components to modern total ankle systems. There's a tibial tray that you see here, and then there is a dome-shaped metallic component, and then there's also a polyethylene liner in between the two. If you read the literature, you'll see that there's a fixed bearing system. These are referred to as the 2-piece designs, and what that means is that the tibial tray and the polyethylene are locked together so that these are fixed together and there's no motion. There's also the 3-piece designs, which indicate that there's no attachment of the polyethylene aligner at all to either two of these components. Now, there's a huge controversy between which one is better, and an accepted advantage of the three-piece design is that there is a reduction in shear and torsional forces at the bone-implant interface. However, the effect on the polyethylene liner is unclear. I've been to many foot and ankle society meetings, and this is one of the hotly debated topics about what's the effect of having this extra bearing on the polyethylene. There are some who feel that it decreases the weight of polyethylene wear, and then there's others who believe that the wear rate increases due to the additional polyethylene interface. Another hotly debated topic is the amount of edge loading between the two and three-piece designs, and I don't think there's going to be any answer to this soon. And then if you have a mobile bearing polyethylene liner, then that can dislocate, and that's a unique complication of the three-piece designs. What's interesting, though, is the clinical results right now don't really contribute to an answer. It's still very controversial. 5-year survival rates are similar between both implants. So if you look at three-piece designs, the 5-year survival rate is between 70 and 98%. And then the 5-year survival rate between the two-piece designs are between 80 and 97%. If you go to 12 years, the survival rates don't change much. The BP ankle, which is a three-piece design, has a survival rate of 92, and the star ankle is holding steady at 95.4% survival. The two-piece designs, which is the agility, is at 89%. But the rates of satisfaction between patients are equal, and complications are comparable. Lastly, the last controversy is, is fusion better than arthroplasty? Most people consider arthrodesis to be the procedure of choice for recalcitrant ankle arthritis. And recent studies do show that there's high union rates, there's improved outcome scores, and there's a high patient satisfaction. However, with time, and I mean 10 to 15 years, the surrounding articulations become arthritic. And the limb with the arthrodesis also has a high incidence of pain, disability, and activity limitation. There's actually no level 1 or level 2 studies comparing arthroplasty to arthrodesis. And when I looked in the literature, I could find 2 small non-randomized studies that compare the outcomes of these 2 procedures. And of course, they conflict with each other. Dr. Kofid's study in Sweden looked at 13 patients, one group with arthroplasty and a second group with arthrodesis. And his arthroplasty group fared better. There might be a conflict of interest. McGuire looked at 18 patients who underwent arthrodesis and compared that with 23 patients with arthroplasty. And the arthrodesis patients did better, but this study was done in 1988. Nelson Suhu looked at the California Hospital Discharge Database and looked at reoperation rates. He was able to find about 4,000 ankle fusions and 480 ankle replacements in 10 years. And he looked at the short-term outcomes and adverse events. And what he found was that in the arthroplasty group, 9% had a major revision surgery at 1 year and 23% at 5 years. But if you look at the fusion patients, only 5% had a reoperation that was major at 1 year, 11% at 5 years, but 2.8% had a subtalar fusion. So I guess this favors the fusion patients. Haddad did a pooled meta-analysis of the literature at the intermediate and long-term outcomes of arthroplasty versus fusion. 10 studies assessed arthroplasty and 39 evaluated arthrodesis. The studies lacked a consistent methodology and a uniform set of data. But despite the limitations of the study, the intermediate and long-term outcomes suggested that these 2 procedures were equal. But the authors did recommend that a prospective direct comparison study with objective tools and similar cohorts be done to compare arthroplasty with fusion. And so in 2007, the Canadian Orthopaedic Foot Society launched a multicenter randomized case-controlled trial comparing the ankle arthroplasty versus arthrodesis patients. But there's no published data yet. In the United States, we only have 4 options to look at when we do total ankle replacements. There's the Agility total ankle system, there's the Salto Solaris anatomic ankle system, there's the in-bone total ankle system, and there's the STAR total ankle system. The entire body of evidence to evaluate the American experience of these 4 designs is limited to several retrospective case series, all level 4 evidence, and they report the results of a small group of surgeons. I'll just discuss the Agility LP system first. This is a 4th generation implant. It's based on over 20 years of clinical experience. It's been around the longest and has the most amount of research available. This is the difference. This is the previous generation, and now the LP finally has provided an implant that covers the talus fully, which is to try to prevent the subsidence that the talus does with the earlier generations. What's interesting, though, is there's no paper yet available on the LP system. The LP is a semi-constrained 2-piece design. It's made of titanium on the tibia, cobalt chrome on the talus. It requires an arthrodesis of the syndesmosis, and if you follow the technique guide, you should put an external fixator on as well. There's 6 implant sizes, and we require bony end growth through a beaded surface. The literature is shockingly old. This is a 2004 paper. It's from Knecht and colleagues. He looked at 69 ankles in 67 patients. It was an independent review of a single surgeon. He had at least 16 years follow-up, and it was retrospective. 90 patients reported decreased pain and were satisfied with their outcome. The average sagittal range of motion was 18 degrees, and 76 had some evidence of peri-implant radiolucency. And 8% had syndesmotic non-union. He had 14 cases, or 11%, requiring a major revision. 7 underwent arthrodesis. And the majority of the implants that failed were from impaction, loosening, or migration of one or both of the components. This is a patient from this institution, done by Spirit in 2004. 360 agilities were looked at from a single surgeon. 58 of these cases were considered complex, and that meant that they required adjuvant procedures to correct malalignment or instability. 85 cases, or 28%, required reoperation, either for removal of bony end growth or they needed an extra-articular realignment procedure for recurrent deformity. 52% of these came from the complex group. 33, or 11%, were considered failures. Most required revision arthroplasty or conversion to fusion, and 8 below-knee amputations were needed. Migration or subsidence of the talus was the mode of failure in nearly all of these cases. But in summary, though, there is a high rate of satisfaction and pain relief with most of the agility implants. Implant survival and good function may depend on patient age, and non-union of the syndesmosis and specific patterns of lucency have higher failure rates. This is the in-bone total ankle system developed by Wright Medical, and it is a modular implant, so you can add as much of a tibial tower as you can. It's installed via an intramedullary alignment system. It is unique in that sense. There are 5 different sizes. It has by far the thickest poly available, but sadly, despite it being around since 2006, there isn't one single publication on this implant at this time. This is the implant that I use the most often, especially for complicated revisions. This is the Salto Solaris anatomic ankle. It has been modified from a mobile bearing prosthesis available in Europe. So in Europe, the polyethylene liner is not attached to the tibial tray, but in the United States it is. And this was FDA approved in December of 2006. There's 3 tibial sizes and 4 talar sizes, and the radius has 2 distinct radii of curvature that mimic the native talus best. And there's only 1 paper published on this implant in the United States. This is a published paper from Kaiser Permanente in San Francisco. All they looked at was the changes in range of motion after the Salto ankle was placed during the first year. These were 90 cases by a single surgeon. The mean age of the patient was 57.9 years. And what they showed was that at 3 months, the range of motion was about 15 degrees. At 6 months, it was about 18 or 19 degrees, and maybe at 12 months, it reached 20 degrees. and the greatest improvement occurred between 3 and 6 months. And lastly, this is the STAR total ankle system. It was recently approved for use in the United States within the last 5 years. There are 5 tibial sizes, 5 talar sizes. It's the only mobile bearing prosthesis available in the United States and will likely be the only one available in the United States. There is up to 14 millimeters of poly thickness available, and there's only one long-term outcome paper from the United States. This is from Roger Mann's group, published just a few months ago. They looked at 84 stars and 80 patients followed prospectively by 2 surgeons with an average follow-up of 9.1 years. 91 of the prostheses remained implanted at 9.1 years with a probability of survival of 96% at 5, and that it goes to 90% at 10 years. There was an average 39-point improvement in outcome scores with a 92% patient satisfaction rate. So the future is computer-navigated assistant. There's already been a cadaver study published, and we'll see how that goes. It will certainly be exciting to see the results of the Canadian and the Harborview study comparing arthroplasty versus arthrodesis. Thank you.
Dr. Hansen, some final thoughts?
Well, I want to tell a little story that I hope will be one of the things that will make you change your practice, and it applies very much to what we've heard all day today. The other day I got a request from a physician in the Midwest to see a patient of his. Well, this was several months ago now. It said she'd had an awful time. She went in to have an arthritic ankle fixed. She'd had a fusion for post-traumatic arthritis many years ago, and she was having all the symptoms that have been explained that happened with subtalar arthritis and so forth. And so the surgeon in their town said, well, yeah, we can do a total ankle by taking down your fusion and doing a total ankle replacement. Oh, great, that would be wonderful. So he did that, and after the operation, a number of problems occurred. The patient, after initially, because of having a block, was okay. Then she woke up with severe pain. And I should tell you that, first of all, that what he did to try to keep her from having pain was elevated the leg and put on one of these polar care device on her foot, because he really wanted to keep her comfortable. And he thought to really keep her comfortable, he also should elevate it quite a bit. And then he went off to his daughter's wedding somewhere and left his minions, I guess he must have thought they were, in charge because they were afraid to change his orders. The patient woke up and had this terrible burning pain in her foot, and she begged them to let her put her foot down or do something for her pain. And they said, well, we can't do that. The doctor left the orders, strict orders, the way we were to leave you, we can't change it. The nurses couldn't change it, the residents couldn't change it. They had to do exactly what she was left to talk about, which Pietro told us what we should do about that. The team should interchange information and opinions enough and work like a team that if something happens and the boss is gone, they can change things. If you take a leg, and this is very different than the hand, because the problem only lower extremity and foot surgeons have, is you elevate the leg, the arterial pressure goes down, but the venous pressure does not change much. I think we all think that if you want to elevate a leg to get better drainage, the better you elevate it, the more it drains and the better you are. Well, part of the problem is it doesn't get any arterial supply when you get it up high enough. We should all know that by being good observers, that if we know that we're in the operating room and we do want to do a gastroc slide, if we elevate the leg about a foot and do the operation, it doesn't bleed. And if we're having a little excessive bleeding in the foot and we want the tourniquet off, just elevate it a little bit and it doesn't bleed so much. Leonardo showed this, and he made little things to show his characteristics, his principles many times. He made a column of a barrel like, or it would be a carboy nowadays, and then he put tubes out of it in different ways. And he showed at the top, the water just drizzled out, and as you went down at the bottom, it came out as a jet of water, so that the pressure at the lower end was much higher than it was at the top. In compartmental syndromes, you don't want to elevate the leg. The way you treat them is to get the leg down so that you get a better arterial pressure, which differentiates a good arterial pressure from the venous pressure, which doesn't change much, so that you can get pulse through there. Well, apparently this surgeon didn't know that stuff, even though it's been there for either 500 years or 30 years, and in my book it was put up very clear with a lady with her foot or looking like she was anguished with her foot up and then looking much better when her foot was down. It's called the elevation ischemia syndrome. So anyway, this lady's dorsum of her foot and her lesser toes sloughed, and she had terrible problems, and eventually they amputated the lateral side of her foot and cleaned up the front and put on the vac and did some skin grafts and got her foot healed up. But meanwhile, the ankle that had been put in had dislocated by the fibula fracturing and then stretching out the deltoid, which may not have been very good. So she's in dire trouble. Well, somewhere along there, I also got a request from attorneys in the same area. Would I see this patient that they didn't give me any name of? But I talked to the patient finally. It turned out to be the same patient that I'd been contacted in 2 different directions from, unbeknownst to each other. And I said, what's your blood pressure? Oh, it's normal. Well, is that low normal, high normal, what? Well, it's about 120. And so I said, well, and what did they do with you after the surgery? Did they elevate your leg? Oh, yeah, it was really up in the air. I even took a picture of the thing they put it on, the foam that you put your leg way up like this. And so she's got the terrible triad. She's got elevation, and then cold applied, and then she's got a low blood pressure. So they were putting ice on a limb that had virtually no blood supply. So what'd she get? Frostbite. It's exactly what it looked like. So now we've got to deal with this patient who has a bad ankle, and she's had part of her foot off, and she's had this terrible triad, and I have to figure out what I say about what this surgeon did, whether is that malpractice or not, because people don't know about this syndrome very much, even though it's been well published, and like I said, for hundreds of years, the interest of what happens when you elevate a leg. So what I'm hoping is that in addition to all the other talks, maybe you will remember when you see a leg elevated on the ward after foot surgery or after a crush injury or something, you'll say, hey, don't put that up more than 6 inches or maybe 10. The other thing I would recommend to all the people that are attending is when you go on rounds with your residents and your fellows, how are they going to learn this except when you come around, they got to hear it at least 10 times. So you go around and see your patients, one of them's elevated too much, you bring the nurses in, and say, let me tell you something. This is what happens, and we go over this story I just said, until they finally learn that you don't see legs elevated like that if you want them to heal. Okay, somebody take that home and make me feel better that you learned something. Any questions?